The purpose of this lecture is to look at the age-related changes as it relates to cardiovascular pathophysiology. So we're going to look at the changes in cardiac circulation as we make that transition from fetal to newborn life. We'll also look at common cardiac abnormalities in children. These are primarily structural abnormalities. We'll look at the big three. And then we'll also look at how cardiovascular function changes as we get older. I think it's important to look at how early the cardiovascular system develops. As you can see, the cardiovascular system is one of the first functional systems that develops during fetal life. If we had very, very sensitive indicators, we may be able to pick up that heartbeat by as early as 3 weeks in the developing fetus. The critical time for heart development is in that 3 to 8 weeks of very early fetal life. This is a critical time for abnormalities that may develop if there is a negative event or insufficient material to support development of the heart. This is one of the things we look for in a mom who might have rubella during the first trimester of pregnancy. That increases the risk of cardiac abnormality during that first trimester because of the critical time frame is that 3 to 8 weeks. As you might remember from your undergrad, and if not, we'll go over it, oxygenated blood from the placenta enters the umbilical vein and leaves through the umbilical arteries. And this is a critical concept when we think about fetal circulation. The other critical concept in fetal circulation is that highly oxygenated blood is shunted through the foramen ovale and enters the left atrium. Now this makes sense because in fetal life, there isn't a need for the lungs to function in terms of picking up oxygen from the air because there isn't any air. This is a fetus. But we do still need to circulate those lungs for cell growth, and so that's why it's still important to circulate the lungs, but not to pick up oxygen for respiration, but to pick up oxygen and nutrients for cell growth, just enough to keep the tissue growing and maintaining those tissues. So once that highly oxygenated blood shunts through the foramen ovale, it enters the left atrium. From the left atrium, it goes to the left ventricle and then out through the aorta. Most of the blood bypasses the pulmonary artery through the ductus arteriosus to the aorta. And of course, then it goes to the rest of the body. Now, what's important then is following birth, the foramen ovale needs to close after birth when we expand the lungs. In addition, it's important that the ductus arteriosus also close. So let's track that through those changes at birth. We know that at birth, oxygenation of the baby's blood has to shift from the placenta, which is connection to mom, to the pulmonary system. As soon as that umbilical cord is clamped, that increases the systemic resistance and decreases the intravascular return, decreases the return to the heart. So as soon as we clamp that aorta, it changes the resistance, and that's what helps close those two openings, the foramen ovale and the ductus arteriosus. With that first breath, pulmonary vascular resistance falls, pulmonary blood flow increases, and that full process takes about 14 to 21 days, because remember, those openings do have to close, and the baby has to have a chance to do that. The ductus arteriosus itself begins to constrict and usually has made good progress in closing within 12 to 24 hours and becomes fibrotic within about 2 weeks. Now remember, in the fetus, this was part of the lung bypass. If this ductus arteriosus does not close, it's a patent ductus arteriosus, and blood continues to bypass the lungs, and that is one of the abnormalities we'll talk about. The foramen ovale closes because of that increased pressure in the left atrium, so that makes sense. And then also the ductus venosus also has to close shortly after birth. This usually goes pretty well. Although it may remain open, it is more likely that the arteriosus or the foramen ovale may fail to close. We know that congenital heart defects affect about 1% of live births. And congenital heart defects are the most common birth defect. Let's look then at some of the cardiac abnormalities that we're likely to see in children. Now, what I've done here is I've listed the 3 more common ones that you're likely to see. There are others that are in the system, but they tend to occur much less frequently. My expectation is that you understand how these abnormalities, these structural anomalies, affect blood flow and then also workflow or workload on the heart, and then how they present. So we're going to go all through of those. We're going to talk about blood flow, how these abnormalities or anomalies affect blood flow. We'll talk about workload, and then we'll also talk about manifestation or presentation of that. So let's start with the most common structural abnormality in a child, which is a VSD, or ventricular septal defect. It's estimated that this may affect anywhere from 25 to 30% of children. But we also know that in many cases, although it's the most common structural abnormality, most don't cause hemodynamic problems. However, if the defect does not close, you do have a left to right shunt, and that's important. And that makes sense because remember, you've got with change in the fetal to the newborn circulation, high pressure is on the left, low pressure is on the right. So if this defect if this ventricular septal opening, which was important in fetal circulation, fails to close, you're going to have a left to right shunt. When that happens, then you're going to have more work on the pulmonary artery, the left atrium, and the left ventricle. What this will result in over time, if it fails to close, is heart failure as well as increased pulmonary vascular resistance. Now, this increase in the pulmonary vascular resistance is due to a decrease in the diameter of the vessels because those arteriolar walls become thickened because of more pressure. This usually manifests as a holosystolic murmur, and remember where this is. This is in the ventricle. And so this is a holosystolic murmur usually found in the left lower sternal border. So that's why when you think about cardiac structural abnormalities, you have to remember your anatomy and where everything can be heard. A second structural defect in children is the patent ductus arteriosus. Now remember, that was an opening that bypassed the lungs, but it doesn't close. And as a result, that's why it's called the patent ductus arteriosus. This causes left heart stress. So what happens in this is blood flow is going, once it continues to go through this ductus arteriosus, therefore you have increase in the pulmonary blood flow, which then increases the work on the left side of the heart. So this is going to cause left heart stress. When we assess for this, the manifestation, again, in all 3 of these defects that we're going to talk about, you're listening for a murmur, but the placement of the murmur is critical. So in a patent ductus arteriosus, the murmur is usually holosystolic and holodiastolic. It's in the left upper sternal border. Now remember, this is different from the VSD. In the VST, you found a holosystolic murmur in the left lower sternal border. In a patent ductus, you're going to hear that murmur in the left upper sternal border, and you may hear that all the way through systole and diastole. The third defect that is a bit more common is the atrial septal defect. Once again, think about your pressures. This is a failure of that septal tissue to actually form, so it doesn't close the defect, that hole that was there. Once again, as in a ventricular septal defect, the blood shunts from left to right because you're going from high to low pressure. As a result of remember this is now in the atrium, and so the right atrium would enlarge. Left to right shunting, so the right atrium will enlarge, and as a result you also have right ventricular enlargement and an increase once again in pulmonary blood flow. This is also manifested as a murmur. This is a systolic murmur, usually heard at the second to third intercostal space to the left of the sternal border. Now, all of these defects become very important because, as we've talked about them then, there are ramifications for increased pulmonary blood flow, and so therefore you may see some pulmonary hypertension, but also you've increased the workload on the heart. So all of these three can lead to heart failure in a child. Table 33-5 in your textbook is a great table because it summarizes the congenital defects that can lead to heart failure. And again, I do expect that you'll have an understanding of how these defects that were supposed to close, but they didn't, how it affects blood flow, where the workload will be manifested, and the character and the manifestation, which is mostly going to be in a murmur and the placement of that murmur. Now, what we do know is that children with cardiac abnormalities, these defects, have an increased risk of hypertension, obesity, and then also have negative effects on their cardiovascular health. Because you can imagine if these defects don't close and you continue to have increased workload on the heart, the child would present with heart failure. So what happens as we get older? Well, we know that there are a number of changes that can lead that, although they happen with aging, and this is once again where we cross that idea between what's normal aging and what's abnormal. But there are four key issues that we want to think about here because they are very important pathophysiologically. One is the deposits of calcium. As we get older, we are much more likely to deposit calcium in our arterial media, which remember is the muscular layer of the vessel, as well as on our valves. The other thing, so you have calcium deposits within that muscular layer, which will affect the ability for those vessels, once they expand or dilate, to contract back down, as well as calcium vegetations or calcium deposits on the valves will lead to valvular incompetence. And those vegetations, those calcium deposits are very hard, and so as a result, the valves simply aren't able to close competently. As we know, there is also an increase in the development of atheroma, that idea of arteriosclerosis, atherosclerosis. Now, this is affecting the arterial intima, and it's important that you have a good understanding that calcium deposits occur primarily in the media, whereas atheroma development is an intimal disorder. We do know, in looking at least people in the U.S., atherosclerosis increases as we age. But so does but the incidence and the sensitivity to the inflammatory process. So as you look at the atherosclerotic process by itself, that atheroma, as well as inflammatory changes that are common as we age, you have that classic atherosclerotic lipid buildup and the inflammatory process that facilitates that. A third important piece in pathophysiology as we get old is that our response to our baroreceptors becomes less efficient. Remember, baroreceptors are in our brain, and it tells our body to constrict our vessels. Well, if those are less efficient, what this leads to then is an increased incidence in orthostatic hypotension. So baroreceptors are there so that when we stand up quickly, we constrict, we maintain our blood pressure, we don't get dizzy. So as we get older, with that less efficient response of those receptors, when an elder stands up, that efficiency isn't there, and so they're more likely to experience dizziness, and their blood pressure doesn't rise the way it is supposed to physiologically. The fourth piece that's important to look at in terms of aging and cardiovascular physiology, pathophysiology, is systolic hypertension. Remember those calcium deposits, that atheroma development? Because of increased resistance and decreased contractility of our vessel walls, as we get older, we are more likely to develop systolic hypertension. And the best way I have to explain that is that we lose that ability to snap back. So as a result, then, that our systolic blood pressure continues to go up. Diastolic may stay in a fairly normal or slightly elevated range, but in elder, you may see systolic readings in the 180s or the 190s because of that loss of resistance and contractility. So what would this lead to then? What type of heart failure is this likely to lead to? Sure, it frequently leads to a left-sided reduced ejection fraction heart failure. And that's because, once again, you've lost resistance, you've lost contractility, and so individuals with systolic hypertension are more likely to experience orthostatic hypotension as well as reduced ejection fraction heart failure. So we've looked at a couple of different kinds of things in age. We've looked at how physiologic changes occur from fetal to newborn circulation, and it's important that we have an understanding of the hemodynamics of that. Because when those openings that provide bypass of the lungs don't close, or other openings like in the ventricle don't close, that then leads to structural abnormalities, cardiac abnormalities in children. When you look at those cardiac abnormalities, think about blood flow, think about workload, and think about where that murmur would be, because the ones we talked about will present as murmur. And then once again, as we get older, we have to think about what's happening to our arteries, to our valves, and what's happening to our sensitivity then to our baroreceptors and our ability then to maintain normotension and be able to keep our pressure up when we get up quickly. I appreciate your attention, and please let me know if you have any questions at all. Bye.